Hello and welcome back to another Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to cover another topic with you, which this week is going to be late preterm infants. Before we begin, if you follow me on social media or maybe you saw, I did have oral surgery on Friday and my face is still a little bit swollen and I've had like a little residual, kind of speech problems because I have stitches in there. So if I sound funny, I'm sorry, that's why, but I promise my pain is low and I feel good recording this. But just wanted to let you know in case I sound different or look a little different today. But I have been asked to cover late preterm infants, and there's a reason I wanted to cover this today. We are doing it in two parts. Today, we're going to cover some common issues, and then next Tuesday, we're going to talk more about feeding difficulties, the lines we place on these babies, and what their discharge looks like. And one of the reasons I wanted to cover this is because you may not know this depending on where you live, but when temperatures get really warm in the summer, we tend to have more women in labor or having signs of labor or going into kind of this early late preterm labor because of the heat and dehydration. People also sometimes just experience contractions for those reasons. So summer can be a pretty booming time for the late preterm infant. So I thought this would be a good time to just go over this. So let's dive into it for this week, where we're going to talk about kind of the background and common issues. So we know that the definition of late preterm is 34 and 0 to 36 and 6 sevenths. And that actually is kind of the cutoff for many units for what they automatically admit to the NICU. Some units, if you've obtained that 34 and 0 sevenths, they'll let you stay on mom baby, do some extra observation. Some units not until 35 weeks, so depending on kind of what your cutoff is, along with a weight cutoff, just something to think about. And then up to 36 and 6 sevenths is considered late preterm. And I think what we're going to talk about a lot today is this idea that a late preterm infant is not just a small term infant. And while we may think that they are very similar to term infants, they're actually quite different. And we're going to go through some of those things today. And often they may appear stable and good for a while and then end up transitioning to the NICU at 4, 8, 12, 24 hours of life because of some difficulties. So we know that this is about 75% of what's considered a preterm birth. I know that we have this idea that the NICU is just booming with 22 weekers. It's not. We have them by all means, but a big portion of our admissions come in this late preterm population. About 300,000 babies are born late preterm in the US every year. 36% of these infants will be readmitted to a hospital for jaundice or feeding issues or breathing problems or failure to thrive, something going on with them. So if we discharge them too soon before they've really proven to us what they can do, then they can get into trouble. So let's start diving into some of these common issues. Obviously, thermoregulation is going to be high on this list. Late preterm infants lose heat fast because they have less brown fat and thinner skin. They have an immature temperature control center up here in the brain. Remember, the brain is not fully functioned or formed until the baby is between 37 and 40 weeks. So all of those little pathways you've seen, I know you've seen probably the pretty stark contrast between what a 22-week brainer looks like and what a 40-week brainer looks like. But these babies fall in between there. So something to think about. If the temp goes below 97.3, not great. If they're cold, not great. If they are having blood sugar drops, why are they having a blood sugar drop? Ask yourself. If they are using all of their energy to stay warm, they are going to burn their sugar and their sugar is going to drop. So those two things often go hand in hand. And that's really important to recognize whether you are a mom baby or postpartum nurse, a level 2 NICU nurse, or even a level 3, 4 NICU nurse. These all go together. So we should be keeping their hat on, use servo-controlled open warmers when they're admitted, doing skin to skin. If we are admitting in a crib, making sure we're using appropriate layering. And if they're going to have a lot of labs drawn, maybe the crib isn't the best place for them because they're going to lose that heat so fast. Another common issue is hyperbilirubinemia, and that's because they have this breakdown of their red blood cells, but they can't clear the bilirubin fast. That's because they have less mature liver and their liver enzymes and their poor feeding. So I heard someone say this recently, and it's really to think about, pooping is lower bili. So if we're not getting the poop out, then the bili's not going down. So getting it out and really thinking about How can we know if the bili is going to be dropping? And that's a sign is that they're pooping. So something to think about there. We need to be tracking that. A lot of level 2 NICUs or our newborn nurseries are going to do like the transcutaneous bilirubin, which I think has a great place as long as we know how to do it and we're doing it consistently and watching for those trends. You can use something called the bili tool, which is online. You put in the baby's age, age at birth, hours old that they are, and how many weeks they were when they were born, and it'll tell you what their risk is. I love bili tool. I think it's a great thing. It's BILI tool. Just go look it up. I love that a lot of times when I'm talking about bilirubin, the closed captioning will turn this into BILLY, but I think you all know what I mean. We need to really understand that this idea is that the feeding is really what's getting the GI tract engaged so that we can flush out that bilirubin, and we don't want to miss any of these bilirubin checks. An interesting fact, if an infant is born in a birthing center or even in a hospital that has a birthing center, the baby will come back at 24 hours of life, for one thing being a bili check and another thing being feeding, which we'll talk about as well. Another common issue is respiratory distress that leads to the need for high flow nasal prongs or CPAP. So these infants are often, going to have TTN, so trans TTN. I'm like stuck. Transient tachypnea of the newborn. I don't know why I'm stuck here. TTN, TTNB, and that transient, right, is the idea that it is short-lived and the infant will recover from it. However, this combined with respiratory distress syndrome and this idea of what needs to go on in the gas exchange means that they may end up needing CPAP or high flow nasal cannula in the first 6 to 12 hours. This is that idea often that they present with grunting. Remember, grunting is auto peeping. Peep is positive end expiratory pressure. So if an infant is trying to hold their own peep because they want that gas exchange to be happening at the alveoli level, they're going to get into distress. So you'll hear people be like, oh, look at their cute little cry or their whimper. They're not whimpering. That is a grunting baby and they will go down fast. So watch for that and then watch for any desaturations or any work of breathing. Additionally, we may have an infant in respiratory distress that requires intubation or surfactant. Surfactant production really kind of ramps up in that third trimester. So anytime a baby's born early, and if you're a baby born to a diabetic mother, IDM, that also increases your risk because insulin, right, that's being pumped into the baby is going to break down the surfactant. It inhibits surfactant production. So they're at even higher risk for having surfactant deficiency. And you're going to see that in those first few hours. And again, they may present well and then not do great. So they may need to be intubated and given surfactant. We're going to talk about families at the end, but this is one of those really big ones that can be super difficult for families, especially when they've looked really well and they've hung with the mom and the dad and the family for a while, and then all of a sudden they're in the NICU and they're intubated. Can you imagine? I mean, all NICU admissions are traumatic, but this would be, I think, especially hard. So let's talk about the one that we probably all know, and that's feeding difficulties. Feedings work. These babies fatigue fast, especially if they're right at that borderline of 1,800 grams to 2,000 grams. The closer you're born to 34 weeks, the less likely you are that you've developed suck, swallow, breathe. Remember, suck, swallow, breathe is a pathway that must be formed in the brain. So if the baby hasn't formed it yet because they're born early, that also is going to increase their risk. They may not cue well. They may have poor tone. Poor tone, when you think about we always think about poor tone as this idea of a floppy baby, but poor tone is also the tone of what's going on in their throat, in their airway. And if that has poor tone, then they also are at risk for aspiration or difficulty swallowing. So this puts them at greater risk for aspiration, poor weight gain, and hypoglycemia. So trying that, cue-based feedings, watching to make sure that their feeds aren't going too long. And remember, that gavage feeding may be what they need to get us through a period of time, especially if they need to rest, especially if they had respiratory distress and they're just coming off of that. Really giving the baby this idea that their baby's not failing. They're not going to be in the NICU forever, but we need to support them through this period of time. I think another thing to really think about is that normal output doesn't always mean adequate intake. And this is something that I can tell you as a NICU nurse and a mom of a 39 and 1/7 squeaker. I was exclusively breastfeeding my daughter when she was born, and she pooped and she peed and she slept. Okay. All the signs that they tell us, like your milk production's great, your milk production's great. We were nursing, there was milk, you could see milk, right? She was doing great. Take her to the doctor at 10 days of life, right? We had been in the hospital, went home. A week later, we get to the doctor, and she had lost 14% of her body weight. She looked like it, to be honest, in hindsight, but she was showing signs that she was gaining weight and she wasn't. So, fast forward, turns out I don't really make any milk, and we started giving her formula and she did great. But that's just a personal story of something that happened to me. And she wasn't even a late preterm infant, but we had like, kind of a traumatic birth together between a birth and a C-section. So I think that she was just tired, and then I didn't make enough milk probably from all that together. And so kind of set us up for failure. So keep an eye on your late preterm infants. These infants are also at risk for sepsis, and this can be because of their immature immune system, right? In addition to the other things that they are tested for, in addition to any experience having PROM, if mom has GBS. So looking for the signs, you know, apnea, feeding difficulties, modeling, temp instability. Temp instability that's not recovering when you put them under a warmer, putting them in an incubator and it requiring such a high temperature to keep them warm that like this isn't quite right, something's going on here. So thinking about a CBC, a CRP, a blood culture, knowing what your unit does when we're admitting these babies for low temperatures, and kind of what is the protocol. Does everybody get a screening CBC to kind of see where they're at? Who do we give the blood culture to, and who would get antibiotics? So all of that's kind of a cascade to think about. Temperature often is a reason that they're admitted, but why? Is it just because of the brown fat? Is it because they weren't properly kept warm in mom baby? Or is it because of sepsis? And it's always something that should be sitting right here for you to think about. In these babies, we are going to watch really closely for their glucoses, especially if there's any signs of poor feeding. Their bilirubin, which we've talked about, their calcium. These babies have an interesting time kind of processing their calcium, so that's something to think about. A CBC or CRP, and then, of course, their electrolytes. And especially with our glucose and our bilirubin, having to repeat them, having to really follow a trend. I know in every unit I've worked on for our late preterm infants, we had a protocol that said, hey, when you're born at this age, you're going to do this many sugars, this frequently until you have this many over 60 or whatever the case was. So having those hypoglycemia protocols and knowing exactly what to do, it helps really kind of take away that guesswork of, hey, we're going to get this many sugars. And it tells the parents this is how often we're going to poke. If the infant is exclusively breastfeeding and the parents have some autonomy to get the baby out, being like, make sure you call me because we're going to do a sugar before every feeding to watch to see what's happening. So make sure you're having that really thorough communication with them. So that brings us to our parents. I do think that this is one of those tricky admissions. I know I said at the beginning that every NICU admission is traumatic, and I stand by that. I think even if you're in the NICU for 4 hours, it's traumatic, especially the mom baby separation. So if you are kind of like in your third trimester, you're at 34, 35, 36 weeks, you may think that this is going to go by quickly and everything's going to be okay. And then the baby's transferred to the NICU or admits to the NICU right at birth for respiratory distress. It is really hard, and we can't give them a great timeline of when the baby's going to go home. I think we really have to watch them over those first few days to give us an idea of, okay, was this respiratory distress that's quickly resolving with CPAP? Was this respiratory distress that required intubation and the baby's still intubated? Was this a temperature problem? We were able to get them warm in the incubator. We're going to keep them in there for a few days and try to transition them to a crib, kind of see what happened. So the babies may not even look sick, especially if they're eating and breathing and pooping, but not warm enough. So just something to think about when you're talking to them, kind of taking into consideration how traumatic this could be. The best we can do in these scenarios is just to support them and help them understand what would need to happen for discharge, where their baby is kind of on that progression towards discharge, and how we can be supporting of them along the way. Which leads us to the end of today and knowing we are going to talk about discharge readiness and kind of how These babies sometimes turn around fast, and how we as NICU nurses can help the parents prepare, how we can be getting our education done, and how we can support them through that. I want you to really think about all of that cascade of things that can happen, especially when the baby is born, maybe stays with mom and dad for a few hours, see some signs of temperature regulation problems, respiratory problems. So, what can we do to support them? How can we communicate well with our labor and delivery or mom baby team if the baby's admitted directly to the NICU? Does this still mean that we can do skin to skin? Does it mean that we can monitor the respiratory status closely so we can get them off faster? So I think thinking about what are the most common things I may experience. So if you're the admit nurse and they call and say, hey, we're going up on a 35 weeker, we're not sure if the baby's coming down or not. And then they call and they say, hey, we're bringing the baby down. Start thinking about what is the cascade of events that could go wrong for a late preterm infant, and reminding yourself thermoregulation, blood sugar issues, feeding problems, respiratory problems, and this risk for sepsis. Keeping all of that in mind during your care of the baby and your care of the family and supporting them through it is going to be super helpful. So, join me next week for part 2, where we will dive further into this patient population.